Greetings and thank you all for joining us. My name is Sanjeev Silva, head, neck and thyroid surgeon and director of the Sapien Care Group. Welcome to today's Sapien Care Group webinar session. Today we'll be discussing how the COVID-19 pandemic has caused collateral damage in cancer diagnosis, referral patterns and oncological treatment. Are patients less likely to go into their GP surgery and check any health concerns? Does telemedicine consultations pose a challenge to patients expressing themselves and on GPs on picking up red flag symptoms and signs? How bad has the pandemic disrupted oncology services at the hospital? I'm very pleased to welcome a new member to the Sapien Care Group team, Ashok Handa, who will be chairing today's webinar. Ashok Handa is an associate professor of surgery at Oxford University and consultant vascular surgeon at the John Radcliffe Hospital in Oxford. Guest speakers today include Global Authority in Cancer, Professor Carol Sikora, Chief Medical Officer of the Rutherford Health. He will be joined by Senior GP, Dr. Roger Henderson, who regularly appears on television and radio. And finally, we're pleased to have Alison Kay. Alison's been involved in the field of cancer for over 20 years, and she's the founder and president of Ovarian Cancer Action. Finally, as we often have at the end of many Sapien Care Group webinars, we'll be closing with music and a video by Charlene Spiteri singing Windows of My Mind. Please type your questions into our webinar platform. We'll try to get to them. Be reassured that this webinar will be available on demand on our website, so you can come back to the contents if you have to leave during the live session and view the topics covered later. And without further ado, I'm going to hand you to the very capable hands of Ashok.
So, a warm welcome to all of you to this fifth in the Sapien Care series on COVID and cancer. I'm really delighted to have three distinguished speakers today in conversation with me. Roger Henderson, Alison Kay, and Carol Sikora. We know that cancer is responsible for 40% of all deaths in the UK. And you might say, well, why do you want a surgeon involved? Well, we know surgery cures 50% of all cancers that are cured. And so it's particularly important to have a perspective from surgery as well. And more importantly, we will be able to take your questions later on in this live webinar. So without further ado, I want to welcome our first guest speaker. Dr. Roger Henderson is a very experienced GP and a media doctor. He was the medical columnist for the Sunday Times and writes on health matters for the Spectator. Welcome, Roger.
Thank you very much indeed.
Could I start by just saying, why do you think patients are so reluctant to seek medical care for cancer during the COVID pandemic?
Well, I think I would almost take one step back from that initially and say that we all are agreeing that there is a surge coming of patients who are out there, who have not presented to their GPs, with potential malignancies developing. Unfortunately, cancer doesn't take a holiday, it doesn't take a furlough. It moves on 24 hours a day, relentlessly. Now, many of those patients have a double whammy because they're often over 60, over 65. So they are in that unfortunate position of being at risk from COVID and increasingly statistically at risk from developing a malignancy. And we have the lockdown causing reduced numbers of patients coming into surgery because of patient anxiety. And all of that has led to this unknown bubble in terms of numbers of patients out in the community who have potential new malignancies. Now, there are a number of reasons why patients may not attend. And perversely, the government message, stay at home, save lives, protect the NHS, may be working against us here because it's actually been very effective. And especially the elderly population have taken that to their hearts. They are staying at home. Even while the lockdown is starting to slowly ease, they are staying at home. Now, they may be completely unaware of danger symptoms, and I think we'll touch on how to get the message about what danger symptoms are out there later. So they may be unaware of danger symptoms. They may be aware of those symptoms, something is not right, but scared to attend because of the risk of developing COVID or catching COVID in a GP surgery. Or, as is always the case, there may be a small number who are fully aware, but ignoring for whatever reason, who just choose to put their head in the sand and not attend. So the question is, how do we get to those patients who we know are out there, but who are reluctant to attend our surgeries because, rightly or wrongly, they feel they may be at increased risk of developing COVID once they get into a surgery. But perversely, they're probably more at risk from going around the supermarket than they are coming to see people like me in a surgery.
So there's clearly this fear and people aren't coming up. What sort of things can you as a GP and those working in your practice do to encourage patients to seek medical advice?
Well, I think the key thing is to have a message that's tremendously simple. You don't get it down into sort of micro messages. You don't try and get out 100 different symptoms that a patient might need to look out for. You get the message out that we are open for business. You get the message out that if you have concerning symptoms, we want to know about it and we want to see you. Now, every practice in the country will have different ways of doing that, but a number of things off the top of my head you could look at, and which I've looked at. The practice website, for example, most practices now have very good practice websites, and patients often go to those as first port of call. So you can have on the practice website the message that if you have concerns, come and see us, and you can put on a list of red flag symptoms on there if you want. We mustn't forget that on the right-hand side of prescriptions, practices can put any message they want on. Typically, you'd put the flu day dates on, for example, but you can put any message you want on there. So you could put a message on there about red flag symptoms or concerns, and patients would see that. Obviously, if a patient comes into the surgery, you would have signs in the surgery. And any contact, you have to make every contact count. Any contact you have with a patient, whether that's with a GP, with a practice nurse, specialist nurse practitioner, healthcare assistant, or receptionist, and this is important, it has to really start from the roots up in a practice. Everybody has to be on board with this. They should be aware of red flag symptoms. If a patient rings in with possible symptoms, the receptionist knows when they should be taking serious notice of them. So all that and some other things you could do raise awareness, I think, because it's all about saying to the patient, it is safe. Because if they hear from the practice that it is safe to come in, perversely, they're probably more likely to come in to see us than if you have the Prime Minister saying it is safe to come into the practice. They actually believe what we say because we are used to them and they are used to us.
Yeah, so I'm interested that you say they could use it on the internet, on your websites, but of course, a lot of the older patients don't use the internet and are not as au fait with IT. How do we get the message to those particularly vulnerable patients who are perhaps older?
Well, I think you probably have to have a campaign where you use every contact with those to ask specific questions. Do you have any symptoms you are concerned about, or any new symptoms you're concerned about? Because let's not forget, we are starting to pick up our hypertensive clinics, our diabetic clinics, our asthma clinics. We're starting to see the older population in many of those. Now, it is a given that if you ask a lot of patients the question, do you have any symptoms you are concerned about, you are going to get an awful lot of patients giving you an awful lot of answers. But I think that is a price that we have to pay, because if this webinar and if the message that we get out does one thing with one person, and that could be your parent, my parent, it could be family members, friends, people we know, if that one person goes to their GP and their cancer is picked up that otherwise wouldn't be picked up, from my point of view, that's a result. And I would extrapolate that everywhere around the country.
Yeah, so that's good. So we get the patients in, see their GPs, and one of the things patients are worried about is, there's no point going to my GP because they won't be able to get me in to the hospital or to see the specialist to have my test. So how are we going to help to manage patients to make sure they get then into the system to have the diagnostic tests and to see the specialists?
I think there are two areas we look at here. One is very, very local, and that's GP pressure into local CCGs and local secondary care. And one is right at the top. And I think Carol may touch on this, but I'm going to use the C word, which is cash. There has to be a massive national drive to put funding and resource into dealing with this surge. We have an absolute motorway of patients with possible malignancies coming at us. We know that. My concern is if that motorway in primary care then goes on to an A road at the primary care, secondary care interface. And we all know what happens when a motorway goes onto an A road. You get a log jam and you get a traffic jam and backlog. And if anything, that's my main concern. And I think that is the drive that central government, that the NHS really need to be looking at. Otherwise, all bets may be off.
Roger, finally, I want to ask you, in a typical practice, say of around 5,000 patients, how many patients per week would you normally see where you've got some worrying symptoms, and how many are you seeing now?
I think in a normal week, I mean, obviously it's a hugely variable factor, but if I had, say, 5,000 patients in my practice, I would probably have 3 or 4 consultations a week where I was thinking, I'm not liking the sound of these symptoms. I can tell you precisely what has happened to me in the last 2 weeks in terms of those numbers, and that's a big fat 0. No one. And I think that illustrates the point. Okay,
Roger, so the phones are not ringing and the people are not turning up. Is that what I'm hearing from you?
Okay. That's what you're hearing from me.
Thank you. We'll come back to you for the general questions. Thank you very much. I want to now go on to welcome my second guest today, Alison Kay, MBE. She is the president of the Ovarian Cancer Action. She is past chair of Cancer 52, which is the voice of those 52 less common cancers. And she has huge experience in working in cancer for around 30 years. So welcome, Alison. You might want to give us a few words of background to start with.
Well, on my own background, I've put here that I'm a pioneer for change because, you know, being involved with cancer for so many years, we see the same stories going round and round again. And I think that, you know, we really need to think about this moment and not just, you know, fix something that's gone, you know, is going to be very difficult, this backlog of patients, but also to use what we have to change the future. So I think we've got a moment in time where we can say, we'll just fix things, or actually take time to reinvent some of the things we know we can do way better at, because the NHS system is just the most fantastic, you know, system to do research in. And you know, in terms of patients, you know, I was listening to Roger, and you know, as somebody who's involved with the charity, we've given a very different message. You know, we've said please stay away, and we've noticed as well that patients are worried about wasting doctors' time. And you know, people have been very, very, very effective at staying away from A&E. But while all of this has been happening, we've missed out on all the screening that we should have done. I mean, there's huge backlog on screening. We've missed out on early diagnosis, and what that means is that we could shift the stage at which cancer is diagnosed. And for something like ovarian cancer, what that means is actually a lot more people will turn up at A&E. We watch those figures. And so a change in stage means A&E presentation, not even to GPs. We know that existing health inequalities will get worse. And then there's all the sort of hidden losses, which is that a lot of research had to stop because of this. A lot of labs that did basic research, they had to give their chemicals away to COVID labs, and they've got to restart all that work again. A lot of cancer research is based on modelling through animals, and all the animal research has stopped. So innovation has basically stopped as well, and vital experiments lost. So, you know, we're at a stage where we've got to rethink not just about dealing with the patients that we've got a backlog of and the patients still coming through, but what we're going to do for the future to really improve things.
So Alison, picking one of those things up, could you give us a feel for the size of the problem? I think you might have some data to share with us.
I do. And this is going to be a first for me, sharing my screen. And this data has come through. Are you seeing that correctly?
Yes, we are.
Are you seeing the whole screen?
Yes.
Yes. Okay, so you can see a lot of these figures are from June and from the NHS, and you can see here that 15% of people wouldn't attend hospital. But actually, when NHS changed the way that they questioned and used the words COVID, you can see that 44% are concerned with catching the virus. Well, I'll let you see the figures yourself. And what the estimates are is that there's going to be 50,000 extra deaths in the next 5 years. Generally, 165,000 people die of cancer every year, and they're estimating that this year it will be 200,000. So it's a huge problem. And I think also the 1-year diagnosis. So what's happened is that the cancer will come along faster. So there'll be more deaths within a year than we generally have. I hope I've done the screen okay. I'm a little lost now myself.
Yeah, no, you have.
I'm lost somewhere within my own computer. Sorry about that. Yeah.
So, Alison, one of the things I wanted to ask was that, if you were a patient, what would a good pathway look like to you now? So if someone is worried about cancer, what would you want to happen from a patient's point of view?
Yeah, well, slightly different to Roger. We would want remote appointments wherever we could, wherever possible, wherever you don't need a hands-on intervention or a face-to-face. Patients are very much like the remote appointments. And even though people over 65 may be less used to using computers, I think this period of time has really improved that. So wherever possible, that's what we'd urge. And we'd like to minimise waiting time. I saw at the Nightingale Hospital that they're planning to set up, there may be an appointment system to go to A&E. So however long a patient has to sit within a surgery or sit within A&E, that time needs to be minimised. So it may be that we can put in some kind of appointment system, and also perhaps flexible working hours, so that a GP surgery is open for longer hours, so that the waiting room is actually emptier when there's a patient there. And patient involvement is something that many of us have talked about over many years, and patients love to be involved with their own care. And I think that one of the things they can do is to keep a symptom diary. It's something we've done at Ovarian Cancer Action. You can print it off as a paper version, and all that helps the patient to have a good communication with their GP, because that really is the most important thing. And on the symptom diary, it'll have every day of the week, bloating, yes, Monday, yes, Tuesday, yes, Wednesday, or fatigue, or whatever it is. And I would also urge patients, if they know what cancer they've got or suspect what cancer they've got, to go to the specialist charity sites where there can be an awful lot of help. We know that referral times have been longer, and I think we'd like to shorten that, but I think patients are very understanding and in the main well behaved. And I think something that we've touched on as well is the holistic side of things, that where possible, a patient's mental well-being needs to be looked out for. And we at the charity, we have been involved with other charities, and we have webinars 3 times a week. And we have updates from the government every week, which we send out in email form. So it's not just the GP that patients, or at least patients who know what their cancer is, can go to. There are other forms of information out there.
So just to build on that, what sorts of things are cancer charities and patient organizations already doing that you think is good stuff to do at this time?
Yeah, well, I suppose that anybody who's looked at the poster for this event will see that it was Piccadilly Circus behind us, and our charity used a lot of online messaging actually to say cancer's still there, don't forget about it. And we had a lot of outdoor sites. We've used a lot of Facebook groups to reach people. We've run programs for people who are shielding called Stay Away, Stay Connected. Obviously, we need to change our messaging now. And we've done quite a lot to do with exercise and yoga or mental well-being, or helping people sleep through messaging again on social media. And And I would urge people to actually go to the specialist cancer website like Pancreatic Cancer UK or Prostate Cancer UK, rather than just going to Cancer Research UK. And a lot of the research charities, because we've been unable to continue with our research, have moved over to doing much more patient care work.
Okay, so if you know what cancer you've got, get in touch with the designated cancer charity rather than a generic one.
Exactly, yes.
Okay,
Yes.
well, thank you very much. We'll come back to you on when we have the whole panel. And I'd like to now move on to my third guest this evening, which is Professor Carol Sikora. Carol is the Chief Medical Officer of Rutherford Health and founder of Cancer Partners UK, which is the largest independent UK cancer network. He was also the founding dean of the only independent medical school at Buckingham University. So Carol, it's a great pleasure to have you on the panel, and thank you for making the time. So perhaps I could just start by saying, you know, what do you think is the size of this problem of cancer in the UK?
I think it's really bad. We have a serious problem, Ashok. And if you look at the statistics released from NHS England only 2 weeks ago, the first factor is that on June the 7th, quite why that day was selected, but it was, the NHS activity was only 40% of normal overall. You know, one can query how that estimate was made, but that's their own data, which compared to other European countries is pretty poor. Most European countries, albeit those who have been through the pandemic 2 or 3 weeks ahead of us, are nearly at 80% activity by their own estimates. If we look at other parameters, overall admissions down 85%, 2-week wait for cancer down 60%, breast referrals down 78%, and a particularly bad one is endoscopy. No one's been doing endoscopies. It's down 90%, only 10% of normal activity. We've heard about the waiting times. The waiting times on the waiting list are a lot of surgical procedures, obviously not just cancer. No one really knows how many there are, but I suspect the figure that's being bandied around is 6 million. Some say by October, it'll be 10 million and growing. And in there, there'll be cancer patients. So we've definitely got a problem. To me, the best metric of how to get out of here is to follow the weekly biopsy rate with for malignant disease. That to me would be the best figure to look at. And the reason for that is obviously that's where cancer is diagnosed. That's where the cancer registry starts. The minute the pathologist certifies the cellular pathology of cancer, that's the patient logged into the system. And the difficulty is it's not an easy figure to get. And I've been round eminent pathologists, both in London, Oxford, both public and private sector, and they can tell me the total number of biopsies coming in, but they can't tell me the cancer biopsies without going through each one in the lab and coding it themselves by hand, which to me was slightly surprising, but that's what I'm told. But if we look at the overall biopsy rate, it plummeted. In April, it was down 92%, and in May, it was down 88%, so very significant falls. So we clearly have a problem. What's the solution? That's what we need as a solution to all this. And really, there are two things about COVID. Either it's going to peter out now, and that's my interpretation, but then I'm optimistic, the positive professor on Twitter and so on, or to use some of my colleagues' very pessimistic viewpoint, it's going to come back with a second wave in September, which is going to come into winter pressures. Everybody's going to have lockdown. We're going to be back to protect the NHS messages, which is going to screw up Roger's evangelical work to get his patients back into his primary care. It's going to screw up diagnostic pathways again. I hope I'm right, and everyone hopes I'm right, but somehow they think I'm not, and I'm not quite sure why. You know, the epidemiologists loved gloom and doom because that's how they make their money. That's their business, to be gloomy and doom about it all. But when you look at Public Health England's report, it's a super report, comes out every Thursday. It came out today, I've looked at it. Everything looks good to me. And the best litmus test of how we're doing is the telephony inquiries to 111, NHS 111. And they're coded by computer on the algorithm, and you can see it's fallen right off. And you can pick up the Leicester problem, you can see that in there, and you can see a variety of other local hotspots, but it looks okay to me. It looks as though we're getting out of here. I think we have no alternative to plan for getting out of here and getting cancer services back. So how do we do that? The first thing is we need information, and the best information is the biopsy rate. We've got to get that. We've got to understand how things are changing. The weekly biopsy rate in every region of the UK. The second thing we've got to do is create cancer centres as COVID-free zones. How do we do that? We take the temperatures of everybody coming in. We get the staff tested both for the virus by PCR every week, and we test their antibodies if we like, but as we've learned, antibody testing only picks up a small percentage of people that are positive, but we've got to keep our cancer centres COVID-free. And then after that, we've got to use the metric of the biopsy as the way forward. And then going on, you know, I'm a great protagonist for the independent sector, having spent most of my life as an NHS consultant, now working in the private sector. I think, you know, the private sector has 26 radiotherapy units scattered around the country. They're not just London-centric. I agree, there's a lot of them in the southeast. That's the nature of private medical insurance. There are 65 chemotherapy places that you can have chemotherapy delivered. There's no reason we couldn't see a joint effort to bring them into the NHS.
So, Carol, just to go back one step. Now the biopsy rate obviously is an important way of testing that, but of course that's almost at the end of the diagnostic pathway, and the people waiting for tests further back. So, you know, someone might have, say, for a suspected colon cancer, they might have a endoscopy first, and a biopsy, or they might have a CT scan. Are there ways that we can improve or streamline those pathways so we don't go through this sequential test and get to the definitive test quicker?
Well, I think that's what we have to sort out with people like Roger in primary care. So let's take someone that comes to a GP surgery with a cough, with hemoptysis, coughing up a little bit of blood. How can we deal with that? So Roger could refer for a chest x-ray, so it shows a shadow. But then we need to get a CT scan sorted out. And then we need to get a bronchoscopy. And that's the tricky one. And the risks escalate. So the risk in terms of COVID escalate. That's what I mean. That the bronchoscopy is the riskiest bit because someone's got to put a tube in down and risk the fact that there may be a cloud of virus coming out if the patient hasn't been tested. So clearly it's important to test the patient for the virus before you start doing interventional procedures. With colonoscopy, slightly less risky, but you know, really the key diagnostic path for making a diagnosis of colon cancer is to do a colonoscopy. And if we can't get that done, and now it's coming back, it's beginning to come back, we've got to get the logistics right to do that.
So, Carol, just to go back on that, I mean, I know that, you know, we all agree that there's going to be a problem with late referrals, and I'm looking at a question from one of my colleagues from Oxford, Nick Maynard. But, you know, in the normal situation, in, say, the 2-week cancer wait, the pickup rate of cancer is often less than 10%, and in some centres down to 5%. And although the referrals went down, what we do know is that the pickup rate now is significantly higher. So it may be that we're out of this, the people with symptoms that weren't really red flags for cancer are not coming. And we've got to be able to be smarter as we deal with this increased numbers or the backlog.
Yeah. So the 2-week wait is an interesting concept. I remember it all in 2000. I was on the group that came up with this scheme, and Mike Richards was charged with implementing it. And, you know, the problem with it, it's not, and people blame the GPs for the fact that we're behind Europe because the 1-year survival rate is lower for cancer in Britain than the rest of Europe because the diagnostic pathway is slower. It's not the GP's fault at all. There's no way, even the smartest of GPs, the most erudite GP, can pick up cancer that compared to the next one. There are some cancers that are easy to pick up. Breast is pretty easy. There's a lump, you refer to a breast clinic. Others, pancreas, ovarian cancer, very difficult because multiple symptoms, not classically cancer, mimicking all sorts of other things. So actually trying to smarten up the diagnostic pathway, it's all about access to scans, access to the biopsy, access to the key sort of critical investigation for that type of cancer. And at the moment, certain cancers are easy. I mean, leukemia, for example, there's not been a problem with the diagnosis. That's done from a simple blood sample. But some of the others, much more difficult.
Sure. Now, the other area you talked about was increasing the capacity of the NHS and using all that spare capacity in the private centres. Now, somebody might say, well, of course you're bound to say that, given that you're leading the largest UK independent healthcare. And of course, it's not that private practice hasn't been without its scandals of over-treatment and mistreatment. And so how would we make sure that the governance was up to the standards that we expect in the NHS?
I think what we have to do is give the control of the protocols to the NHS. So the idea would be, it would be locally based. So if you take Oxford, for example, where you're based, Ashok, you've got within 30 miles, you've got 3 or 4 actual private cancer centres, 2 of which have radiotherapy. Basically, for the surge, which is, I think, going to come later than we think, I think it may not come till August or September, to treat those patients effectively, give the local NHS oncologists, some of which already work in the private centres, but give all of them the opportunity to use them to treat their patients as necessary. And it could be just for specific diseases. So the 2 diseases that drive chemotherapy usage in the adjuvant situation and radiotherapy, again in an adjuvant situation, is breast for both, colon for chemotherapy, and prostate for radiotherapy. And they're, just because of the numbers involved, they're the ones that are going to be the problem for downstream post-surgical treatment, or the only treatment for radiotherapy for prostate cancer. So it's clear that as we move forward, integrating the private sector with the NHS seems a reasonable way forward. And it's happened sort of with the surgical approach to cancer. The 19 COVID-free centres that were created sort of tried to do that to different levels of success in different parts of the country.
So I want to move on to my last question for you, which is that obviously we had the announcement that the Nightingale hospitals are going to be repurposed as cancer centres, and the idea that there might be this factory of 1,000 beds or 2,000 beds to do it, it's not entirely clear to me how that's going to work out. But do you think there is a proper comprehensive plan in the NHS to deal with this both backlog and ongoing cancers, and a lot of the people who are going to refer late, and Alison also alluded to those that haven't had their screening done. So there's these 4 groups of patients all coming us at the same time.
Absolutely. And you know, the bottleneck is imaging at the moment. There are MR scans and CT scan waiting times now have gone up through the roof. So one estimate puts MR scanning 1,200% increase in the waiting list, the waiting time compared with pre-COVID. So how the Nightingales could be brought in, I'm not totally sure. They could be used to give chemotherapy quite easily. They obviously can't deliver radiotherapy. Can they do diagnostics? I'm not sure what their diagnostic capability is. I assume they have CTs or mobile CTs because you need that for COVID management. I'm not sure there's much else there. There probably isn't MR in most of them. But they provide an area that you could use for certain types of cancer screening, but you know, most cancer screening needs very little. It just needs throughput. It's a high volume throughput business.
So we need to use the places that already have that diagnostic ability rather than
Exactly. And maybe extend the working day. And that revolves money, of course, to do that, but there's no reason it couldn't. We did it with COVID. I mean, you know, the NHS handled COVID superbly. It twisted the battleship on a different course. Now the trouble is getting it back on stream, getting it on course to deal with heart disease, with cancer, mental health, all these other things that it's a day-to-day work.
Well, that's thank you so much for that, Carol. I think it's a good time for us to open it out to the full panel and welcome Roger and Alison back. I wanted to start with a question from one of the listeners, James Coulter, said that if stress reduces immunity and with lockdown causing huge stress for many folk, do you expect a rise in the incidence of cancers? I don't know, should we start with Roger on that?
It's a question that often comes up, and there's been a fair bit of work done on this over the years. And the way I would put it is the jury is out. Certainly, stress is not good for the immune system in general. There's no clear evidence that it would trigger a malignancy, but I think if you were to have one, then in an ideal world, you wouldn't be having lots of stress knocking around at the same time. I think there's a separate strand to that, which is not only are we going to see a cancer surge, we are undoubtedly going to see a mental health surge simply because of lockdown. And interestingly, I'm already seeing the effects of that coming through in surgery ahead of any latent malignancies that may not have presented yet. That is currently the lead horse of those two. And I think, again, you know, mental health has occasionally been a Cinderella speciality in terms of funding, and that has to be addressed because that's going to come across all age groups. Now, I know cancer can affect all age groups, but there is a slight loading towards the elderly and the increasing age. So stress per se and cancer, not proven, but not helpful. Stress and COVID for sure, put your mortgage on it, and funding for both cancer and mental health, absolutely crucial.
Thank you. Alison, do you want to come in on that? I think you're still muted.
Yes, in terms of patients, it's some of the patients have been ones that have had to shield, and there have been partners shielding with them, and I think it's been the stress not just for the patient but for the other person, so that, you know, in all of this we mustn't forget the person who's looking after the patient. I think there's been you know, a huge amount of worry there, and I agree with Roger that, you know, it's a question that's always asked: how much is stress involved, how much is diet involved? And we've never had the real figures to be able to extrapolate one from the other, and I don't know whether we'll be able to do that at this time. It would be great to think that we could, because we know we've all had a massive amount of stress, but I'm not sure how the mathematicians will be able to unpick that answer. Yeah.
So I want to move to another question. I mean, to all of you really, but perhaps as you're in the chair, Alison, you might say, how prepared do we think the NHS is for getting on top of those who've been waiting for treatment and those who've been waiting for tests over the next few months, as we're gearing back up towards 80% activity or more?
Oh, that's a difficult one for me, because I don't work within the NHS. I think from the patient point of view, it'll be hard to get people back in. I mean, I know that we're saying now, well, come back in. I think unless you can promise people that the area they're going to is COVID-free, you may have an awful lot of difficulty. And I also think that we need quick, you know, it's actually the opposite to what Roger was saying. It's not just your GP surgery you want to be positive towards, that's a major help. I think that the government do need to be less woolly about things and really quick. You know, we saw with the flux in Leicester that, you know, the government took 2 or 3 days. And I think that for people to go back into the system, they'll need that, you know, they'll need that extra push. Whether or not the NHS can then handle that is actually probably something that I'm not all that equipped to answer. But I would say that, you know, that if we've got this situation now, and, you know, Carol says maybe it's going to peter out, we don't know that we won't have, this is terribly depressing, but we don't know that we're not going to have other pandemics in the future. And I think, you know, we're really focusing on, you know, CT scans, on equipment at the Nightingale, but actually there's lots of technology that's used in other industries, a lot of AI for symptoms, where we could learn from patient symptoms to primary care, to work it through to secondary care, to find out outcomes and work it back to improve our own symptoms recognition. You know, there are lots of companies out there who would like seed funding from the government. Let's not just put our money all into equipment. And again, with waiting times, you know, you can go to a restaurant and, you know, you can be texted when it's 10 minutes time to be able to go back in, you know, back to take your table. Why can't we use this kind of technology to make sure that patients don't have to wait around? And because we know that hospitals, you know, 20% of the COVID infections came from hospital. So, you know, I think that we've got a lot of messaging to do to change that and to change the way the NHS work.
Thank you. Carol, did you want to come back on that?
I think, you know, technology is the key to the future, just as Alison says, that we've been slow to use it. Everybody uses it better than the NHS. I mean, you know, even primary care, Roger, I'm sorry, you know, you made me smile. I mean, our local practice has one of these national servers. It's useless. It's clunky, useless. You can't get blood tests on it. It's sort of half a service. You have to deal with a grumpy receptionist inevitably to get anything done. And let me tell you, in Beaconsfield where I live, they're very grumpy receptionists. Not that I go there, I'm infrequent attender. But I think Alison's right, technology is the key. And in a competitive environment such as a restaurant, that is it. That's what people are doing. The trouble with the NHS is not competing with anybody. So, and that's one of the fundamental problems in it. It's a great system, and the universality is what we all love. The fact it's free at the point of care and all the rest of it. But there's no incentive to make it smarter for people. And that is one of the problems we have in it. How we can get it better, I think with this, with the post-COVID era where people are frightened, people will welcome, even people that are not used to technology are going to welcome distant communication, telephone calls, Skype, all the rest of it, Zooms and so on, and have consultation. They'll get used to this as part of the normality of 2021 and beyond. And as you say, this may not be the last pandemic to come. We may not have a second wave, as I keep telling everybody, but there may be another virus in a pig somewhere in Beijing, outside Beijing in a farm, that's going to cause far worse havoc than this lot ever did. So we have to plan for it.
Roger, there's a question directly to you, which says that how do you know it's safe to attend the GP surgery? And I guess surely the fact that patients are coming and going means that you wouldn't know who was asymptomatically positive. And so some patients are saying, I wouldn't attend unless absolutely necessary. So how can you reassure them that what happens in the surgery is going to be safer?
I think what most surgeries have done, including mine, is that you have zones. And what you have is you have red zones, amber zones, green zones. And anyone that comes through that door of the surgery has only come in because they've been vetted first. They've had a video consultation or a telephone consultation. Their times, if at all possible, are staggered. So there are very few people in the waiting room or the waiting room in that zone that they come into. Just as the practice staff are wearing PPE, the patients will come in and they will be masked and they will use sanitizer as soon as they walk in. They will have absolutely minimal contact with anyone else who is non-medical in the surgery. And I come back to my basic point: they are more likely to pick something up from going around the local supermarket than they probably are from going in to a surgery. I completely understand psychologically. You know, historically, patients have sat in a waiting room in winter and been coughed all over and come out with influenza or a cold, and that's in people's minds. This is a little bit different. We have completely changed our working practices. So it's not a case of anybody coming in who is concerned about catching COVID just being lumped in a whole sort of cattle truck of people. They are in one very safe part of for surgery and looked after individually with that audit trail of protection following them in and then out of the door as well. I mean, Alison touched on a good point about technology. Technology, in terms of remote technology, video conferencing, for example, is revolutionizing primary care. An awful lot of GPs that were very hesitant about it are now big advocates. And patients who we were poo-pooed it before are now seeing the benefit of that. Problem with that is slightly twofold. It's all very well having high tech from the primary care end, but if the patient at their end has got a truly dreadful piece of technology or the worst mobile phone in the world, the images, for example, can be really, really poor. The second thing is that personally, and I think many GPs may be the same, I could have all the information I wanted from a patient about potential malignant symptoms. I would still really, really only be comfortable referring them on for a 2-week cancer rule if I put my hands on them. Now, that's just me, but I just want to give the secondary care as much information as I can. Mainly it's painted to confirm my fears. I have seen patients like that, and then I thought, this is nothing to do with malignancy. This is a hypothyroid case, and you don't refer them down the tracks. And as you say, 8 out of 10, 9 out of 10 cases refer may not end up having a malignancy diagnosis. I actually don't think that matters, because for that one person in 10 and their extended family and friends, boy, that's the biggest thing in their lives.
Thank you. Well, we're really struggling for time now, and I just wanted to pick up what I thought I heard as key messages from the three of you. So I think the messages I heard are that for patients and public, look, GPs are open for business, and if you've got worrying symptoms, it's good to talk. Call us, and we will talk to you first and see you if needed. And the other thing I heard really was that GPs need to make it explicit to the public that the NHS is open and ready for work. The message I got from Alison really was, look at the high quality information that's out there from many of the cancer charities, and that don't forget cancer, and cancer is still treatable and should be treated. And from Carol, that the NHS needs to plan and work differently to catch up. And from all of you, that we need to use technology at this time to transform care, and not just think working the way we used to 3 months ago or 6 months ago is going to be okay. Because if we carry on like that, we're not going to catch up with that surge of patients that's waiting in the wings or not even turning up. So I just wanted to move on to thank you, my guests. Thank you, Roger. Thank you, Alison. And thank you, Carol, for taking the time to come. I wish I had many more hours to talk to the three of you. There's so much more to explore there. I also wanted to thank Stafford, Nick and Sanjay for setting up Sapien Care and making these seminars possible. And even more importantly, I wanted to thank you, the audience, for taking time in the evening to listen. And if you enjoyed or learned something from that, please pass it on and tell your friends to listen in. And I'm now going to hand back over to Nick to close and have some wonderful music for us. Thank you all.
Well, not quite yet, because we have a question which came in quite early on, which I did sort of send you a message about.
I'm sorry I missed that.
The geneticist. Carol, have you got the message? I'll read it out. So it's the question, and it's about chemotherapy. And James is a molecular oncology geneticist working in central London. And what he said is, I understand that many NHS trusts have changed the criteria on which they offer adjuvant chemotherapy to patients with early breast cancer in order to reduce the number of patients having treatment altogether. This means some patients who would have been offered chemotherapy pre the pandemic aren't now receiving it. Some of these patients clearly will develop metastatic disease. Does the panel think that these trusts will have difficulty in the future defending the decision to arbitrarily change these criteria? So should we hand it over to the panelists, and should we start with you, Alison?
Again, not my specialist area, but what I do know is that there are changes to the way that chemotherapy is given, or there have been suggestions that it should be changed within the area of knowledge that I have. And so I don't think it's just going to happen for breast cancer, but for other cancers as well. So that there may be longer periods that a patient can go without having their chemotherapy. I don't know, it may in the end actually cause, you know, some lawsuits out there, I don't know. But I've seen a little bit of documentation that I can't talk about, which shows pretty much that kind of change, not just for breast cancer. So while everybody's here on the line on that, you know, there's some new breast cancer treatment that I know is being planned that is much shorter in time span than normal chemo. And there's also chemo that pharmaceutical companies could give in pill form. And I'd say those are other things to think about for the future for patients to reduce the time that chemo takes, or give it in a form that people can take it at home, because every day that's not in the hospital for a patient is a good day and improves their quality of life. But I'm going off the topic there a bit.
So Roger.
There will be lawsuits. Put your house on it. Delay in diagnosis in primary care is one of the top reasons for litigation currently. And right at the start of the pandemic, my medical defense organization said words to the effect that we're fully aware of the increased risk at this time through remote consultations, and were anything to come of that, then that would be taken into consideration at the time. In other words, it was just going to be a factor for the defense. It's going to be very difficult teasing this out, because there is a world of difference between someone presenting in pre-COVID times with a barn door malignancy diagnosis that is just missed or ignored or misdiagnosed, and then that goes on to litigation, to a GP being unaware of a patient with a malignancy who presents late, and there is then subsequent litigation. I mean, I would argue that GPs are the super specialists of the NHS. Of course we are. We do 90% of the work for 10% of the budget. And the one thing we are very, very good at is picking up diagnoses. But we are not psychic. We cannot diagnose someone we don't know about or we haven't seen. And this is the problem. So there will be cases. Many of them won't go anywhere. Some will. But I think we always live with that risk. We always live with a slightly defensive practice, or with that hanging over our head. We've got used to it. It shouldn't influence and doesn't influence most of our day-to-day working. We do the best job we can in the current climate, and if there's mitigation there because of it, it will come out in the wash.
Carol.
So it's true, NHS England on the 20th of March issued an edict with 6 priority scales for chemotherapy and 5 for radiotherapy. And it did suggest abbreviating certain chemotherapies. The problem is the way in which it's been interpreted in cancer centres around the UK. Some just sent blanket emails to patients telling them their chemotherapy is now stopped. I mean, it was really badly handled. Others were much more considered. Others just carried on where possible. As Alison said, we converted some IV regimens into oral regimens. So 5-FU was replaced by capecitabine. That's an oral formula for the same drug, same end pharmacology. So that doesn't seem to be a problem. I think it's true, and James Mackay, I know him well, and he's right. If you have something like breast cancer, we have a tailored adjuvant chemotherapy depending on the risk of the patient developing a recurrence. The more the risk, the more chemotherapy, the more aggressive the chemotherapy. It's sort of balanced risk management. And that's the whole basis of adjuvant therapy. You don't give it to everybody, you give it to people in a graduated way depending on the risk, whether it's colon, whether it's breast, whether it's anything else. So the problem is to try and reduce the burden on cancer. We tried to get back from it, and that's where NHS England make those decisions. Inevitably, there was a postcode lottery involved in this, but Now it's back to normal. I mean, that's the great thing. It only lasted a month or so, and people gradually got back. Some of the chemotherapy nurses, some of the chemotherapy doctors, the medical oncologists went to the COVID ICUs to deal with patients. That's all back to normal. The patients have all gone now, more or less. Everything is back to normal business, and the doctors and nurses are all back giving chemotherapy. So I think that was a temporary blip that is now over, thank goodness. It's a matter of, if there was, by any chance, another big wave of COVID, how would we deal with it better next time? That's going to be the problem. How we can preserve cancer patients and their treatment in that sort of scenario. I hope it won't happen, but we have to have a plan.
Look, finally, on behalf of Sanjeev, myself and Stafford, I'd like to thank all of you for being so interesting tonight. Sitting here in North London with the rain and then the sun and then the rain, looking out of the window, watching all of you talk with great passion. I feel very proud, like Sanjeev does, because he's looking at the camera too in the same way that I feel. So I'd like to thank all of you for taking part in the webinar tonight. I know how much it means to each of you personally, but also I'd like to thank the audience, because we wouldn't be able to do anything if we weren't supported by so many people. And what started as a petition, and I'm going to move on to your petition in a minute, Carol, that Sanjeev and I started with your help, Carol, some 3 months ago, has become something of an educational platform which we continue. And next week in Ashlock's Place, Stafford will be back. Stafford's got a great concern about balancing the risk. I suppose one could call it the politician's dilemma. It is the doctor's dilemma of how to end lockdown. And tonight, before the webinar started, we talked about the balance of treating patients and the risks. Stafford's got on the panel next week Luke Johnson. He also has Nigel Edwards, who used to run the NHS Confederation, and Anthony Neuberger. So he's got 3 very good speakers next week. Finally, we do like to end with music. And this week we're ending with music by Charlene Spiteri. It's what Carol requested, and Charlene's happy for you to listen to it. So no better way to end than with Windmills of Your Mind. So thank you all and good night.
Good night. Alice.
I think it's a technical problem with the sound.
Yes, but it's nice to watch Carol's Texas lip syncing.
I got the piano. Should I play the piano?
But there is piano behind you, Carol. Yeah. Yep, sound quality.
So listen, next week we have actually got Ray Gelato performing live. Hopefully at some point the Zoom administrator will take off the mute button, and then we might be able to hear Charlene Spiteri. Otherwise we can't, but we can watch her sing the great song.